developing content for our next cancer plan. I do want to note that this meeting is being recorded, and I just want to, for those of you who may have AI note takers on here, if there's a component of recording on there, if you can shut those off. We've had an issue with that in one of our meetings, and we didn't get a full recording, and we're still trying to get down to the bottom of it, but we will be sending out the slides and follow up from this meeting to everyone. So all right, so here is our agenda today. We're going to do the background and go over the timeline. A lot of you have seen the revised guidance document that we will be sending out again. That we sent out. And so I'll be going over some points for that. Some reminders for all of you. And then we'll jump into the updates because I'm sure everyone is eager to hear what all of the other subcommittees are doing. And then we'll have an open discussion and feedback, and then talk about next steps. So here is our team, our cancer plan team, and also our cancer plan advisory committee, just kind of acknowledging all of the folks who are helping to work on this whole process. I also want to acknowledge Lindsay McDermott, who is our contractor from Sacramento State, who meets with us every week and is helping with this process as well. She's also on this Cancer Plan Advisory Committee slide, but I wanted to call that out. Our cancer plan timeline, there's one quick update on here. And if you see halfway down, almost halfway down, for the week of January 27th, that's when you'll receive your feedback from the templates that you have turned in. All right, so now I want to go through the revised guidance document and just call out a couple of things that did change from the initial guidance document, and also to call attention to some things to pay attention to because some of the templates we received still needed some work. So we're working on sending some of that feedback back to some subcommittees to help us as we start to review your templates. So one of the things that came up that wasn't really explicitly talked about in our guidance, it was in our template sheet and also in this, but again, we wanted to call it out specifically, the data measures for tracking and evaluation. So we do, of course, want to use data measures, when we can find them for tracking and evaluation. And those data measures that you submit to us should be reliable. And that means that, is it a reliable data source where we'll be able to go back in a couple of years, and 5 years, and 10 years, and we may not be able to know exactly how long this data source is going to be around. But if it is a reliable data source, then it's, normally like we've have that continuous list that we've given you of those reliable data sources. We just want to be able to go back when we do a progress report for this cancer plan to be able to find that data source to be able to measure the progress for the cancer plan. Now, we also understand that there may be priorities that don't have data measures, and that's okay. We do want, like I said, that the goal is to make everything measurable, but we know that some of those priorities may not have those data measures. So for those priorities, we would like to for you to include in either your strategies and or your action steps to address the need for identifying, collecting, and reporting data that can be used for future tracking and evaluation. So, and in that particular guidance document that was revised, we did include those examples of that you can see. Also, defining the action steps. your action steps should be more defined and include specific steps on how to implement your strategies. Given the 10-year timeline, outcomes for action steps can be accomplished in a shorter time, not all of them, but we want to allow for flexibility for those routine revisions based on evolving evidence, emerging needs, a changing administration for our country, for example. So that's a good reminder on, you know, the fact that we'll be able to go back and assess some of these things that have been included in the cancer plan for the action steps. And also just in general, we're looking for short, concise strategies. Of course, those strategies are overarching, but the action steps should also be shorter and concise. I know we've received some templates where we have several sentences for action steps, and those subcommittees will get feedback that we need to cut that down a little bit. And then lastly, narrative guidelines. We're still confirming the exact process of what's going to happen with your narrative, but each cancer plan chapter will have a narrative overview with a chapter introduction that highlights key takeaways, key terms, and all references used. This is similar to the template we're following with Wisconsin and Iowa. So if you take a look at that, you can see kind of the structure that we're going for. And so given that, not all subcommittees will need to write a narrative. And we'll be working with our editor and reaching out to various subcommittee members to assist with writing chapter narratives. So I just want everyone to know that I know we've heard from some folks that instead of, you know, including details in some of the action steps or strategies, they'll put it in the narrative. There's probably not going to be room to do that because because like I said, the chapters will, you know, just be a short, concise chapter. And we won't need, you know, a bunch of narrative from all the different subcommittees because, for example, primary prevention will be one narrative, but we're not going to have a narrative on cancer in the environment, HPV vaccination, nutrition and physical activity. That will include information about that in the primary prevention narrative, but it won't be a separate one. So I just wanted to call that out so folks know about that. And you'll be receiving more information on that as we work to confirm that process. And also to note that some of the details and information that you may want to include in your action step that we may ask you to condense can be included in your resources and references as well. So I know we've had discussion with some subcommittees about you know, maybe the action steps aren't enough information for folks to proceed and implement a project. And that's really not the point of, you know, providing the action steps is to have all of these details on exactly how to implement something. So you can provide a resource that points to exactly how to do that, where you found that, like out of the community guide or something like that. So next slide, please. And here is, we wanted to show an example of the template, because I know that, you know, not all templates were completed, and that's fine. And we had, you know, relayed to all the subcommittees that we just need a draft of what your subcommittee content is going to be. So these templates at this point don't have to be perfect, but we do need to be able to have to be able to review the content appropriately. And so, you know, some subcommittees again had to have their sheets returned for us to be able to review the templates and provide that feedback. But we want to give a shout out to those who, you know, to all of the subcommittees really who have turned in their templates. We know this is it's a lot to do. So we want to thank everybody. And then also just call out the tobacco subcommittee and highlight their template as an example. And you see here for their Smarty data measures that they've highlighted here. You don't have to color code them. We're not expecting that. But they have put this their particular data measures in the Smarty format that we expect. And I also want to say that right now, it's very important that we get the strategies and the action steps completed. So if you don't have time to kind of put this in a format, we will have some help from an intern in the spring to help all of the subcommittees ensure that the format is consistent, because it has to be consistent all throughout the plan. And again, I know that some folks don't even have their data measures yet, which is fine. We still have time. These are not the final ones that are going in the plan. We just want to get this idea here. So shout out to the tobacco subcommittee. And again, this is a great example of how to write your SMART-T objective. And then these are some examples of action steps that have been submitted by subcommittees. So we're highlighting that this is under the early detection and screening subcommittee, and there the genetics subcommittee listing these action steps. And you can see here they're very precise and to the point. And then we also have example from the HPV vaccination subcommittee. So shout out to those two committees. Also, we wanted to just highlight our health equity liaisons. So as you are writing your strategies and action steps, ensuring that there is the health equity component included. And here are your contacts for your particular subcommittee. And those health equity liaisons are also included on the general roster that has been sent to everyone. So if you can't remember, if you need to have a reminder, they're also included on that roster. Okay, and so next steps. The Cancer Plan Advisory Committee will be meeting next week? Next week on December 17th. We'll review, the CDOC team will be reviewing your content and returning your feedback by the week of January 27th, as I mentioned. And our standing meetings scheduled, any standing meetings that you all have scheduled before January 27th may be canceled if needed based on when you receive your feedback. So some subcommittees will get their feedback sooner than January 27th. There's also subcommittees that may need to continue meeting to kind of even refine their content to turn into us. And like I said, you'll receive more detailed instruction on your narrative, references, and resources. So also the last point is that additional meetings with previously divided subcommittees will reconvene to ensure consistency and alignment across the priorities within that particular topic. So we'll be scheduling those meetings or working with those subcommittees to do that at the beginning of the year after the content is returned. So probably sometime in February. Also, we will, as I mentioned, each chapter will have those key terms. So we're going to ask you all to list any key terms and definitions succinctly from your priority. The resources, again, please cite those resources used to support your strategies, action steps, and key terms. Which are your references as well, right? So your references need to be cited. And then any resources that you want to be included, make sure you're listing those as well. And just a reminder with communication, we include updates in the newsletter. And then for any other communications, you have myself, Joyce and Sheila, just for these, all of us can help with any point, but officially Sheila is responsible for data acquisition, and Joyce just for helping with the coordination of your subcommittee. A reminder that data and other requests may take up to 2 weeks. And for the cancer plan roster, please do review the roster. And if there are any subcommittee members that need to be removed because they haven't attended a meeting, for example, please let us know. Once we get towards the end of this process, we'll be making sure that everyone is listed correctly for the publication. your organization, who you want to be affiliated with your organization, and also your credentials. Those need to be correct. So that's a whole process in itself. And if we can make sure that people are checking the roster and putting those things in the plan, that just helps us as when we get to that point. All right, I'm going to turn it over to Joyce.
Hey, thank you everybody so much for submitting your templates and your bulleted updates. So for this portion, we're just going to go by subcommittee and provide updates on your progress. And we'd like to allot enough time for each group, 2 minutes, and you'll see a little timer at the top and a little ping when your time is up, just like a gentle reminder so that we can allot enough time for everybody. And we invite you to listen for any areas of duplication, alignment, or collaboration, and feel free to drop any feedback or ideas in the chat. And we'll start off with health equity. This is Ernesto's group. Ernesto, are you on the line?
I am. Thanks, Joyce. So we started meeting right after we had our first initial meeting with everybody. We've had 3 meetings so far. They've been majority just working meetings where we're going over the drafts and developing our action steps and measures. We submitted our final draft last week. We've got some feedback. So in lieu of a working meeting today, I'm going to be reviewing that and sending a more final version to the group for final feedback before we submit our draft again this Friday. So I think just in terms of the SMARTY measures have been a little bit tough for us in identifying resource or actual data sources to link those to. So I think that's going to be the focus for our group in this next version that we submit.
Thank you, Ernesto. I will pass it over to Shannon.
Yeah, hi everybody. Shannon Kozlovich, she, her, hers pronouns. We had 3 meetings with our subcommittee as well that were all working meetings, and they were, just fantastically productive. We have developed a strong list of strategies and goals for increasing SOGI data collection. And in putting all of that together, we definitely learned and solidified the fact that there is a lot of work to do and we have absolutely no baseline data to start from, which means that our priority is not going to be able to have data measures simply because there is no baseline data for us to start from to create data measure markers that are measurable. So a lot of the action steps are going to be more suggestive of what organizations can step into and should be aiming to do and increase within their organization, including some suggestions for what the CDOC coalition should be looking at stepping into and potentially creating baseline data for.
Thank you, Shannon. I will pass it on to Stacy.
Stacy, just wanted to make sure that I can get off mute here. So hello, everyone. So in regards to our 2 priorities, it basically shows on the screen that you're seeing. Our priorities are focusing and addressing key priorities, and I'm going to turn my camera on for you. And so we're focusing on addressing key issues that directly impact health equity in California. These 2 priorities, addressing social determinants of health and increasing access to equitable health care, are interconnected and crucial to improving outcomes in our communities. And so by working on these priorities, we can be part of transformative solutions. That's the goal, that we reduce disparities, improve quality of life, and ensure better access for underserved populations. So in this in our priorities, social determinants of health like housing, education, income, and food security can have a greater impact on health outcomes than medical care alone. So we want to show that for that work. We'll focus on identifying key social determinants of health issues and advocating for policies that create systemic improvements and tackle these priorities effectively. We'll be looking at understanding the needs, identifying the social determinants of health most impacting our communities and barriers to healthcare access, and also build advocacy plans and measurable impact when possible to track progress and ensure our efforts lead to real measurable outcomes, and use evidence-based data, stories, and partnerships to push the policy changes. So that is what we are tackling right now. Thank you so much.
Wonderful. Thank you so much, Stacy. I'm going to move on to the next subcommittee, cancer surveillance. Terrence, go ahead.
Can everyone hear me?
Yes.
Great. So we've actually had several meetings as well. And for our priority one, we've finalized objectives to increase SOGI data reporting and compliance, as well as inclusion rates by 2028 and 2030. And this is for expanding the California Cancer Registry data dictionary. We've also incorporated QI strategies such as PDSA cycles to refine the data collection methods, and have proposed some webinars and workshops. Our priority two, which is enhancing the California Cancer Registry data collection for underrepresented populations and improve data disaggregation. We set targets for our data measures for 85%. Demographic data completeness by 2029. And then we've identified linkages with some other registries to enhance the pediatric cancer data and cancer data reported among the pediatric population. We've also suggested integrating environmental and socioeconomic data sources to provide to the broader cancer risk context. And for priority three, which is increasing our access and utilization to CCR data through innovative dissemination strategies. We've developed plans for interactive dashboards and visualization tools to enhance CCR data accessibility, and establish goals to reduce the lag between data collection and dissemination. We've also proposed feedback mechanisms to ensure data formats meet our users' needs.
Thank you, Terrence. I will pass it over to childhood cancer. First up is Misha's group.
So we are working through the priority one, which is in terms of increasing awareness for pediatric cancer, with emphasis on advocacy, patient family, navigation, education resources, as well as addressing financial toxicity and psychosocial resources. We've identified 6 of our strategies, but we are working towards the action steps for all of them. I think for me, it was a little bit of a disconnect to understand what kind of data measures that we need to use as a group for this priority. So we got a little boggled down into the data metrics, but now I think we have a better understanding, saying that some groups don't have to have data metrics. So that kind of makes more sense going forward. We've received feedback from Sheila about updating our documents, the comments that they've already given. And we have a meeting coming up on Friday. We've met also 3 times before. They've been working meetings, but a few of our members were not being able to meet at that time. So we're trying to, optimize that, and hoping by this Friday's meeting, we would have a solidified plan for all the missing actions on the 3 of the strategies that are missing there. Thank you.
Thank you, Misha, for the update. Christine.
Hi there. We have met about 3 times as a group. Our priority is the second working group on childhood cancer. Ours is distinct from Misha's group in that we're working more specifically on treatment, specifically looking at initiatives that can advance targeted therapy use in pediatric oncology and being able to avoid treatments that pose significant hardship. So we were able to submit 4 strategies. I dropped in the comment section echoing what the first group had mentioned on the need to improve our data capture. Echoing what Misha said, we don't have a lot of strong baseline data to work on at the moment. And so this is an area that we're hoping to improve upon. We aim to increase clinical trial awareness, education, and enrollment. So we have several action steps under this, and I'll highlight a few. Launch a statewide campaign using social media, mobile apps to educate the public about the importance of pediatric oncology clinical trials, sharing information, success stories, and the value of research participation. Advocate for policies mandating insurance coverage for treatment at research institutions and comprehensive genetic testing for pediatric and AYA cancer patients to improve access to targeted clinical trials. Promote the inclusion of clinical trial education in medical schools, residencies, and research hospital training programs in California to teach clinical trial processes, patient referral processes, and effective communication with patients and caregivers about trials. There are others in that section, but for the sake of time, I'll move to our next one. Oh, my time's up. Sorry about
Go
that.
ahead, Christine. You can have a few minutes or
okay.
a few minutes.
The next,
Just go ahead
sorry.
with your slide.
The next one we have is better defining genomic testing rates and evaluate the potential for optimization and trial enrollment. So again, echoing the lack of data there, we were looking at the data dictionary and trying to figure out how it's applied to institutions across California. In general, the feeling is that many clinical trials are powered by genomic data for enrollment, but there appears to be a bit of an inconsistency in genomic testing rates and reporting in pediatric cancer. So this strategy aims to better understand the current genomic testing reporting structure and requirements in California, as well as to try to modernize recommendations secondary to well-established guidelines, but also to fold in a recurrent reevaluation as this technology evolves. And then finally, our last one was increasing awareness of pediatric and adolescent and young adult survivorship programs. There may well be some overlap here between our initiative and the first childhood cancer group's initiative. But basically, survivorship programs are integral in pediatric cancers. But standardized offerings aren't often clear in California. So this strategy aims to better establish a standardized surveillance and testing schedule, as well as to escalate awareness and establish transitional care expectations.
Thank you so much, Christine. It looks like there's some areas of collaboration for childhood cancer and health equity, and I think also with early detection and screening. So thank you so much for including that in the chat. I'm going to move on to primary prevention with Stephanie's group, tobacco prevention. Stephanie, are you on the line?
I think she's on a full day meeting.
Okay. So I will just go ahead and read hers. She went, this group is priority 1, decrease commercial tobacco and nicotine use and exposure, especially in youth, high school students, and among California's priority populations. I will go over the strategy. So there's 5 strategies with 8 action steps per strategy. And their strategies are reduce tobacco-related cancer disease and disparities and promote health equity through tailored interventions, launch culturally appropriate population health campaigns to raise awareness and build community capacity, promote research on the impact of tobacco and cannabis use, evolving product landscape and use behaviors on cancer risk, Lastly, advocate for policies and community initiatives that support ending the tobacco epidemic, reduce tobacco product waste, and promote smoke-free environments. I think this is the fifth one, prioritize tobacco assessment and treatment as a standard of care across all settings. And then they noted, since there's not enough evidence that cannabis is linked to cancer, we will only be including language promoting more research. We'll move on to nutrition and physical activity. I didn't see Bill on the line. Is Sandy available? If not, I will just go ahead and share their updates in these two slides. So they shared their first slide just included reducing obesity-related cancer risk by 2035. The NUPA subcommittee recommends the following. And then they also recommend or expect to reduce California obesity prevalence and shared a table depicted here in this second slide. I will go ahead and pass it over to Dr. Jen Sway for the HPV and Hep E vaccination subcommittee.
She's not here, but if it's okay, I can
Go ahead, Mark.
talk about it, if that's okay. So yeah, we have we have hepatitis B vaccination and HPV vaccine. So we have 5 strategies for HPV and 1 strategy for Hep B. I think we were able to get all our strategies and action items in. I think personally, like cleaning up our Smarty data measure, it's kind of hard because we have 2 different vaccinations, and I was trying to figure out how to include that into one sentence when they both have like different baseline rates right now. So we do have the care data, luckily. So just sort of cleaning that up, and then I guess that would be our next step.
Sounds good. Thank you so much, Morgan. For cancer and the environment, I saw that Catherine is on the line.
Yes, hi. Sorry, we didn't fill in anything for the update, but we have our priority set, and we have developed 6 strategies that are a work in progress, of course. And data measures are, like many other groups, struggle for us. It was interesting to see, and I was very happy to note that that environmental data was listed and by the surveillance group as one of the things that they were looking at. So it looks like there might be a little bit of overlap there for us to take a look at. And we are continuing to work through the excuse me, the idea about how to measure things and defining action steps. This is it's a tough thing, even though we only have one priority.
Thank you, Catherine. Katie.
Hi. Yeah, so our priority has been determined, and it's it's very basic, just reduce alcohol consumption. It was reduce excessive alcohol consumption, but now knowing the risks associated or the risks between moderate drinking and cancer, it's now reduce alcohol consumption. So we're following the Wisconsin cancer plan fairly closely because they have a great alcohol-related cancer plan. So our 3 strategies are first to increase awareness of the link between cancer and alcohol consumption. That would be among the adult population. Second is to encourage the creation of community environments that reduce alcohol use. So that might some of the action steps along that are policies around alcohol outlet density, safer drinking initiatives, things like that. And then increase screening for and treatment of excessive alcohol use. And that would be through brief interventions and digital screenings, and potentially some clinical stakeholder trainings. And with regards to our data, we're looking at using Burfess-Chiz data to measure reductions in past 30-day drinking, past 30-day binge drinking among, in particular, young adults, but haven't quite zeroed in on what an appropriate reduction would be that we could expect over this 10-year period. I still need to look at some of the historical data to determine what would be a reasonable target for us. And thank you, Susan Park, for your very helpful idea to look at underage drinking as a prevention method. And one of the action steps we do have.
Catherine, it's a little hard to hear you. I'm not sure if you need to bring up your mic.
Sorry, were you guys able to hear me at all? Because I was just rambling.
You kind of dropped off a little bit towards that end.
Now it's better.
Okay.
Now
Sorry,
we
I
can-
was just thanking Susan for her suggestion in the chat about preventing underage drinking prevention. So that's all I have.
Thank you, Katie. So next is early detection and screening. We'll start with Haley's group.
I know Haley was out. I don't know if she's on this call.
Is there anyone from early detection and screening group 1 that's able to provide updates?
I think Mary Beth might be the best person if she's still on.
I'm still here. I'm happy to provide something quickly for you.
Sure, thank you.
So we are, we've met several times. We broke our priorities up into 2 separate meetings. So priority 1 and priority 3, we're tackling kind of separate, but then obviously putting things together. But our first priority is to increase public awareness to drive the request for cancer screenings. And then the second one is really involving the healthcare communities. We have a good working draft. I don't know if there's a slide. Do you have a slide of our priorities? Or do you want me to read them, Joyce?
I don't have a separate slide for your group, but I have just your priority 1 and 3 listed here.
Okay. All right. So we have how to the best way to put this. We are pretty solid. We think right now we need some work on priority 3. We have divided into strategies. We have 6 strategies under each priority. And right now we're just kind of cleaning up what those actually look like with some more concrete information and then aligning that to all of the data. So shout out to Haley, who's done a lot of really good background work and all of that.
Okay. Thank you, Mary Beth. Next is group 2, Elise.
Yeah, so our priority within this subcommittee is focused on increasing collection of family cancer histories, utilization of cancer genetic risk assessment and counseling. And a big update from our group is that we decided to add access to surveillance for high-risk patients. We felt that surveillance was kind of distinct from cancer screening and cancer diagnosis that maybe hadn't been touched on in the cancer plan yet. So we've included that. And I think so far preliminary strategies from our group are, first focused on educating providers, patients, maybe the public just about why these different components are important, or how to access these different things. I know there's a comment in the chat, definitely access to this is a big issue. So in terms of increasing access, some of our action steps are focused on possibly training other just training and maybe that includes engaging providers other than just genetic counselors. Definitely cost is an issue. So we're touching on expanding insurance coverage. That's definitely been an issue in this space. Specifically as it relates to surveillance, I think we're thinking about, how do we make sure that there's access to the guidelines about when people should be getting certain types of surveillance. Those recommendations change. So how do people have, are updated of those recommendations? How do we make sure that surveillance is happening, kind of focused on that. And then as others have talked about before, this is a space where we really don't have data. So we do our plan to have a strategy that is focused on data collection within this space so that maybe we could actually, measure something in the future.
Perfect. Thank you so much, Elise. Last is treatment and survivorship. I didn't see Daniel on the line or Christy Munger. I'm wondering if there's anyone else from treatment and survivorship subcommittee that is able to provide any updates. If not, I will just review their priorities. So first is treatment. Priority 1 is increase enrollment of diverse populations in cancer clinical trials. Priority 2, increase access to non-clinical support services. Priority 3 is decrease access of quality cancer care and palliative care. And then for their survivorship portion, is to increase access to cancer support services, including financial education, caregiver support, and psychosocial support. And their last priority for survivorship is to increase nutrition and physical activity among cancer survivors. And I believe this group has met twice. And then they are finalizing their template and will be submitting to the CDOC team shortly later this week. Okay, I will pass it back over to Shantae.
Great. Thank you all for all of those updates. And I'm very excited to see the chat here with several comments related to duplication, collaboration. And at this point, we can take a few minutes to discuss any other areas or any other feedback anyone wants to get on the updates, or if someone needs clarification. I know we only gave 2 minutes for the updates because we wanted to ensure that we had enough time to go through all of them. But if anyone wants to share any additional specifics or again, any feedback, the floor is open. So you can just come off mute or raise your hand, whatever works for you.
Hey, everyone. I did want to say if there are any groups that don't currently have an active participant that is a health equity liaison for your subcommittee, please feel free to reach out to me or let Sheila or Joyce know that you don't have anyone, and I will reach out to the health equity group and see if we can get someone into your space with you to just offer that health equity support for your priorities.
A quick comment for the group. On disparities, one of the webinars that CDOC just put on with UC Davis Health and the Comprehensive Cancer Center and the California Cancer Registry, which I guess could be sent out to everyone. And the title was Disparities in Stage of Diagnosis and Quality of Cancer Care in California by the Source of Health Insurance. And so it's a massive disparity and it covers numerous cancers. So that's an excellent resource, and it has the data that you would need to show that you would want to change that stage of diagnosis over the 10-year period of the cancer plan. So it's an excellent resource. Maybe someone could put it in the chat. I'm not sure of the reference of it, although I might be able to drag it in.
I will put it on the chat.
Thank you.
Thank you, Stoney, for bringing that up. And
great, great webinar. So
thank you. And we will be sending that recording out once it's prepared. It is just to give a shout out, part of the CDOC surveillance webinar series. And we'll be having more of those, next year. Just make sure you check the newsletter and any announcements that come out related to that. Thank you. Any other comments or feedback?
Shantae, I'm just kind of wondering, there are lots of areas of duplication for sure and overlap. And I think it makes sense to get those coordinated, but also to leave them in each of the priorities for which they're necessary. So that I think the overlap is a really good thing and a real opportunity, but I don't want to lose that, strategy or whatever for each of the priorities.
Absolutely. I think, well, our intent is to ensure that if you all have a similar priority, that it is aligned, or even though you're talking about a certain topic, they may be talking about it a different way, and we just want to make sure that it's all on the same page. So don't worry, we'll still ensure that we have that content for each of those areas.
Right.
But the point is to, again, ensure that this is all synergistic. So, but thank you for calling that out, Laura.
Yeah, and I have to say, I mean, given that I've been involved with this for a number of iterations, I think we're doing really well. Everybody should be congratulated because we're really doing quite a good job so far.
Yes, you are. And again, as I said in the beginning, I'm very grateful for everyone who has volunteered their time and all of the work that has been submitted so far. I know that even though some that has submitted aren't complete, it's totally fine. We're still, we're not there yet. So yeah, thank you, Laura, for bringing that up. Dr. Schumer, I see your hand up.
Hi, everybody. Wanted to chime in. This is great work. Very impressed with the progress. And I was curious across this group if folks have been engaged with the community health improvement plans for their local areas or local health jurisdiction work. And part of the reason I ask is I'm just curious if there's already syncing of what shows up as community health improvement plan priorities with some of the metrics and some of the goals of this plan, or that's
Dr. Schumer, you're cutting out.
Where did you lose me?
We heard you ask if anyone's been engaged with their community health improvement plans. I think that was yeah.
Yes. Has anyone
how do we access
been involved with that? So usually it's by local health jurisdiction. So it would be the across the 61, each of the local health jurisdictions across the state have to do a every 3-year CHA, community health assessment, and then they come together and they also sponsor a community health improvement plan process where the community comes and based on some of the data, there's a discussion around the biggest issues of that area, and then what some planning, setting some milestones and intentions for the next 3 to 5 years.
Has anyone engaged with those plans at all?
It's a great idea.
And part of the reason I'm asking, it's a bit of a leading question, because I think when Shantae was mentioning earlier that there's some also intention here around the implementation and the action plans. I think it could be beneficial to mirror language that already is showing up in some of those local health jurisdiction community improvement plans. And there may be a way to link. And because of CalAIM, the managed care plans are being asked to help support at the local health jurisdiction the development of these community health improvement plans or community health assessments, as well as the community health improvement plans. So you'll see a lot of social drivers. So housing will show up in these community health improvement plans, but I'm sure that chronic diseases show up somewhere in those plans, including cancer prevention and early detection. And so it might help accelerate the impact of this larger plan with what's happening locally if we can start to at least think up you all as experts to help inform both and start to bridge. I was just curious to see if anyone has even engaged with those or knew about them.
Yeah, well, it might be, I mean, if there's a list of contacts for those anywhere, it might be a good idea for us just as an organization and for writing the cancer plan to reach out and ask if they would be willing to share their plan if it covers cancer, if they have cancer initiatives in their plan, because knowing whether or not we have or which local health jurisdictions are focusing on reductions in cancer for their local area, that might help us better be able to support local plans as well, or figure out how local plans can step in and support some of the implementation for the state cancer plan.
And even if it's not specifically called out to cancer, I know that some of the sort of intermediary steps, like the nutrition component of the cancer plan, will significantly overlap. The decreased alcohol use will significantly overlap, and Lindsay has also a lot of insight to this as well. So I'm glad that you're part of these conversations, but I just wanted to throw that out there as a nice overlapping Venn diagram. Go ahead, Lindsay.
Yes, we're working on an analysis in a different project of what is in California's local health improvement plans and health assessments, CHAWS and CHIPS, health assessment and health improvement plan. And so it's things like access to healthcare, housing, food security, physical activity, substance abuse treatment. So that's tobacco policy. So those are some things that we're seeing in some of the community health improvement plans across the state. And then now there's this requirement for managed care plans to help invest some of their savings into the priorities of the CHIP. So there's potentially some financial connection there, depending on how many savings there are. And so it's probably more on the primary prevention side of the cancer stream that the CHIPS would align with this work.
Well, thank you for bringing that up, Dr. Schumer. And we can discuss more, Lindsay, in our weekly meetings that we have to see if and how we can incorporate that and then report back to everyone. All right. I think we have a couple more slides, Joyce, if you can. So these are just upcoming holidays that the state staff will be out of the office here. I think most of you all might have these as well, but just a reminder. So Christmas is coming up, obviously, and then New Year's. Our next quarterly subcommittee check-in meeting is going to be next year. It's actually not 2024. It will be March 10th, 2025. And it will be the last check-in with all of you before our April 30th final submission. So just a reminder for that check-in meeting. And again, we want to thank you all for attending from our small but mighty team. Thank you all for all of your hard work and your dedication to this process. And as I said, we're still still moving forward. And so don't get discouraged if if it seems like there's still so much to do. We're going to get it done. We're going to get it done. So thank you all. Any last final comments? We have 5 minutes left. Final comments before we end the call.
I'll say this is Mark Jameson, and really wanted to thank everyone for their presentations. Thank you. Thank the mighty team for coordinating it all. I wanted to see if we could have put together a list, and this is probably part of that process getting to January 27, of like by chapter, what are the measures that are the objectives and measures for that are being considered at this point.
Absolutely, Mark. We will definitely do that. And like I said, our incoming intern, that's going to be one of the assignments to help with some of the data in the plan. So for sure.
Perfect. Thank you.
All right. Well, again, I hope everyone enjoys the holidays. The CDOC team will still be around. So you have our contact information, and I hope everyone enjoys the rest of the week.